Thank you very much to the organising committee for inviting me to PedirhythmX. It's a great pleasure to be here in Boston. I'd like to make the case that not all tetralogy of fellow patients need EP testing prior to pulmonary valve replacement. It was the famous Danish physicist Niels Bohr who said prediction is very difficult, especially if it's about the future, and that certainly is true with respect to tetralogy of fellow. Here are my disclosures. My disclosures are that George Van Heer is my friend, George Van Heer is my mentor, that he's universally acknowledged to be a brilliant man and an outstanding human being, that he's always given me amazing advice, and that I truly hang on his every word. This is a three-dimensional representation of a mathematical complexity. And I put that up because the complexities of post-op tetralogy of fellow are multiple and interacting and make it very hard for us to sort out what the right thing to do is. When I was a fellow here in Boston, Michael Gatsoulis's landmark paper on QRS duration and risk in tetralogy of fellow came out, and that spurned a great deal of thought and research. 5 years later, in a multi-center study, he defined that pulmonary regurgitation was an important risk factor for sudden death and arrhythmias. Boston, the Children's Hospital, and the Adult Congenital Heart Disease clinics, the Brigham and Women's, has been the epicenter of great thought, research and progress on tetralogy of fellow. And when Paul Carey was here as a fellow, he published this very important landmark paper on program stimulation after tetralogy. And one of the important aspects of it was that inducible polymorphic VT, unlike many other conditions, had came with a very significant risk for the patients, and perhaps that's because they were the patients with the sicker ventricles, and we'll talk more about that. Dr. Katja Zeppenfeld, who's debating next door at the moment, published this landmark paper regarding the isthmuses that are critical for ventricular arrhythmias in tetralogy in 2007. And this paper has been the basis of a lot of evolution in understanding and the ability for radiofrequency ablation and cryoablation at the time of surgery. And it's really been very important. And the work that she has developed has been absolutely amazing, as we'll see. Again, based from here, but a multi-center study looked at all the risk factors for defibrillators going off, and it turns out the top three aren't to do with EP study. They're left ventricular end diastolic pressure being high, clinical non-sustained VT, and having a ventriculotomy incision. And lots of work has gone into refining all the risk factors and putting them into algorithms to predict risk, as we'll hear. Another important study that came from here was disappointing in that pulmonary valve replacement did not seem to help with the risk of ventricular arrhythmia or death. And even though there are problems with the study with respect to the controls not being perfectly matched with those who had pulmonary valve replacement, it's been borne out by further studies that having a pulmonary valve replacement doesn't necessarily help you with respect to arrhythmias. More work from Boston, from Tal Giver, who's the head of cardiology at Children's. He's done lots of work on MRI, which is proving increasingly important. And in this paper from 2018, it turned out that right ventricular end diastolic volume was not associated with outcome. although poor ejection fraction, increased mass to volume ratio, and older age of pulmonary valve replacement were. This study that George has mentioned from Colorado was a prospective cohort study where they did perform pre-pulmonary valve replacement EPSs, and in patients who were positive, they proceeded to do intraoperative cryoblation, and in some of those, and then in the patients who had cryoablation, they did a post-op study, and this is what they found, that patients who are of their 70 patients, 34 had a positive pre-op study, predominantly with monomorphic VT, and 31 of those had cryoablation, and those half of those approximately had a positive EP study after they had their surgery. But one of the major problems with this study, which is acknowledged in the paper, that the surgeon and the team did not check for bidirectional block across their cryoablation lines, which is something that's now been recommended and we'll get to. So perhaps if that had been done, there'd be less monomorphic VT at least. Perhaps these patients with polymorphic VT were the ones with sicker ventricles. It's all very complicated. So I want to make the case that we need to individualize our management, that we need to do this in a team effort. We always work in a team with surgeons and with interventional cardiologists, and we make our decisions in conference, and we need to make our contribution. And there are many times that it might be important to do an EP study, but not in every case. Firstly, each contribution to the literature is based on different populations, and these populations are not easily comparable. There's loads and loads of literature. That's the Morgan Library in New York, and there's even more literature on tetralogy than there are books in the Morgan Library. When we think about things scientifically, we can draw Venn diagrams to understand which population we're looking at, and sometimes in things that we are researching and studying, the populations are very clear. But I want to show you the Venn diagram for post-op tetralogy of fallow. It's very complicated. There's different surgical errors, different surgeries, different substrates, and all the literature has different groups, so it's very hard to make plans. Now, I come from Melbourne, and Melbourne was at the lead of pushing transatrial transpulmonary repair of tetralogy, which is now being widely taken up around the world, and has less ongoing complications than transventricular repair, and we're going to talk much more about that. So when the follow-up of the early transatrial transpulmonary repairs was studied, the outcome was very good, and we now even do these patients earlier than we did in Roger Mee's day, and the survival was very good. And in the adult congenital heart disease clinic at the Royal Melbourne Hospital, it's very, very, very few patients have ventricular arrhythmias after tetralogy of fallow, in speaking to my colleagues. So Ed brought together the PACES, a multi-center study to try and create a risk stratification scheme based on clinical history and non-invasive testing. And the plan is that they're going to evaluate that scoring system that they created. But I want to show you one point, that if you look at the surgical error on the right and you look at transatrial transpulmonary repair, that just having a transatrial transpulmonary repair gives you a low risk compared to not having one. which gives you a moderate risk, even in the current era. Pulmonary valve replacement is an investment in the long-term future, and different teams have different thresholds, and everyone's thresholds are evolving, and we're still not quite sure when the best time to do it is, and we still have to individualize it, and that makes understanding all this data very difficult. There are guidelines, and my colleague George is on the guideline committee. And nowhere in the guidelines does it mention at this point you should do an EP study. It says if you have symptoms associated with moderate or more pulmonary regurgitation, then you should have a pulmonary valve replacement. And then if you don't have symptoms, you should look at other parameters. And then if two of those are present, you should have a pulmonary valve replacement. So what does pulmonary valve replacement do? There's just been published a meta-analysis of almost 8,000 patients who've had a pulmonary valve replacement. And unfortunately, there's not once is there a mention of what happened with ventricular arrhythmias. But there's lots of information about improvement in RV systolic function, decrease in RV volume, improvements in LV function, decreased BNP, and the greater the initial index right ventricular end diastolic volume and systolic volume is, the lower the chance of a post-pulmonary valve replacement normalization, which makes sense. And they also pointed out that almost all studies reported data for symptomatic patients, and these patients shouldn't be used to to justify aggressive management in asymptomatic patients. My next point is, why do we need to do the EPS before? Why not after, or why not during the surgery? When George wrote this beautiful article in Heart Rhythm about ablation in the young, he pointed out that the isthmuses that Dr. Zeppenfeld defined are entirely predictable on the basis of knowledge of the congenital heart disease. So you can know where they are and know what to do at the time of surgery without doing an EP study. Dr. Zeppenfeld has gone forward and published this beautiful, very detailed work on the isthmuses and demonstrated that the isthmuses only support ventricular tachycardia when the corridor is narrow, long, low voltage, and slowly conducting. And in selected cases, you can use that information to gained at a preoperative EP study, but not for everybody. Dr. Zeppenfeld's team has also published that about intraoperative cryoblation, and they mention that isthmus 3, the one between the pulmonary valve annulus and the VSD patch, is sometimes protected by prosthetic material, but at the time of surgery is easy to reach. A cryoablation is straightforward to do, and therefore intraoperative cryoablation is appealing, and bidirectional conduction block should be demonstrated after the cryoablation to make sure that the ablation is going to be effective. And people have studied this. This is a much smaller group from the Mayo Clinic, and in 10 or 11% of these patients, they had surgical cryoablation, and those patients did very well. And the paper points out that sudden death is rare in the year after pulmonary valve replacement, and risk stratifying EP study can be delayed. Just this year, this really important work from Sarah Gonham and colleagues in the UK was published, and we now have precision prediction of a subgroup who are most at risk of ventricular arrhythmias and death, incorporating MRI criteria. So it's just about 10% of patients are at risk. They incorporate late gadolinium enhancement in the RV and the LV, ejection fraction, exercise testing with oxygen uptake, BNP, and sustained atrial arrhythmias and age. And this is very important because now we have great precision in deciding who's at risk and who needs to be risk stratified. So we can do an MRI, take all that information into account, and individualize what we do. I rest my case. Well, thank you very much for that rebuttal, George, but you haven't convinced me that every single patient needs to have an EP study before. Many patients will benefit, but not everybody. So here's a nice picture of Ed in his lab. And Ed has, in commenting on Dr. Zeppenfeld's article, has summarized that unfortunately pulmonary valve replacement does not significantly modify the VT risk, that the reverse remodeling you get is too little too late, and that the patients who get the polymorphic VT are those who have more advanced degrees of ventricular dysfunction. All of that stuff we can pick up on MRI. In this beautiful article from Mitch Cohen, and including you, George, we looked at the very complex pathophysiology of post-operative arrhythmias and sudden death in tetralogy of Fallot as defined. And it's so complicated and there's so many aspects to it. That's why we have to individualize it. And in the risk stratification scheme that you offered, which is now could have added to it the MRI data from the UK, that we've got to carefully nuance all the risk factors and aggregate them to make an individualized decision about what to do. Adding the MRI data, here's the data from Ghanem with respect to ventricular tachycardia, and it was only 13% of patients who were in the high risk group, with the others having a very low risk. George Mines was the martyr to electrophysiology. He did a lot of work on re-entry arrhythmias and unfortunately died in his own laboratory. So this presentation to the Royal Society of Canada was made posthumously. And he used to get tortoise muscle, cut a hole in it, and then he'd make some unidirectional block by using some forceps and get circulating excitation happening in the tortoise muscle. And that's exactly what we're doing when we do ventriculotomy in tetralogy of Fallot, and we've got to work towards prevention. Now, Dr. Zeppenfeld has published that if you have a transatrial transpulmonary repair less than 1 year of age, in this beautiful paper based on pathological specimens, that you prevent isthmus 2 and you have a thicker isthmus 1. Remember, it's a narrow isthmus 1 that is associated with arrhythmias. That when you're able to have a smaller transannular patch, you have a broader isthmus 1. Isthmus 4 is the one you only get with certain kinds of VSD, not the most common kind of VSD. So in patients who have transatrial transpulmonary repair, you're only left with isthmus 3. And isthmus 3 can be dealt with during the initial repair or at reoperation, and then you can test that you've caused conduction block and you can sort it. So you don't need to do, in a patient who's had a transatrial transpulmonary repair, you don't need to do an EP study before. So we've learnt a lot about tetralogy, and I think it's important that we keep working hard on prevention strategies, and we develop detailed guidelines that incorporates all the patients, but we're going to have more and more patients with the who've had the more modern surgery. And thank you very much for the opportunity to talk with you all. It's been a great pleasure.